Well, good morning, everyone. I have 7 o'clock on the dot, so we're just going to kick it off. So I know everybody has places to go and things to do. This is going to be a little different format today. I want to talk to you just a little bit about our process in tracking quality here and the reporting processes that we have and how this is changing and why. First of all, I want to ask the audience a question. Does anybody know the only Twilight Zone episode to ever win an Academy Award? Does anybody know what the Twilight Zone is?
Yeah.
The one where they're on the wing of the plane.
What's that?
The one where they're on the wing of the plane.
Yeah, with who plays that? Who's in that episode?
Oh,
Anthony Hopkins.
Captain Kirk. Captain Kirk, William Shatner.
okay.
Yeah, that's right. Well, it was in the final season. It's actually, the answer might surprise you because it was written by a pretty famous author. But in any event, I have another question for you. So, who is this? Who said this? Certainly, we have some classicists in the audience.
Socrates or
Socrates.
It is Socrates. That's right. That's right. I think a lot about quality when I'm not thinking about laryngology. It might surprise you, but I like this line especially. An examined life is not worth living. I think what he was trying to get at there is that our internal reflection and trying to do better is the way that we grow as human beings. And if we're not actually growing, we're standing still and stagnating. At least that's what it means to me. But you can find a lot of inspirational quotes out there on the internet if you just use something called the Google thing. You can get access to a lot of information about or a lot of quotes about quality. I think all of these are kind of great. You can learn by others' mistakes is stupid. I like that. Mohammed, I think we've discussed this before about who's best to learn complications. Learn from others, don't do it yourself. Or the one down in the right lower quadrant, learn from the mistakes of others because you can't live long enough to make them all yourself. And this is the forum, I think, that allows us to provide our trainees that opportunity to learn from what we discover going forward in patient care. And so, you think here, like if everybody knew everything and was perfect, then when we left residency, we would all be doing exactly the same things we did in residency, right? Because we learned the right way and there's only one way and that's all there is and that's that. But that's not how it works because taking care of human beings is challenging. And as you know, medical knowledge is always changing. So, when we talk about this conference here, quality improvement, quality assurance, what does that really mean? Well, quality improvement acknowledges the fact that all things change, our knowledge changes, and we learn by doing. When we take on hard things and we challenge ourselves, we all learn a little bit more about how to actually do that operation or what we are able to do at this current time, or we use a technique over and over again and we realize we're not getting any good results with this. We need to adapt, we need to drop something and invent something new. Another thing about quality improvement that's, I think, an ethical obligation is to share your knowledge with your trainees and pass that on. If you know that there's a better way to do something and you discover that there's a better way to do something, I think we all take, whether overt or not, we all take kind of the Hippocratic Oath to do no harm. And I think that means sharing what you learn in the care of patients with your colleagues so that they also do no harm. And then, of course, quality improvement for us is internal. We grow internally as physicians. It's a lifelong process that never stops. But the only way to really grow, well, I think a key important in growing is self-reflection and thinking internally. And I know, like, we come to some of these QA events and we're like, it was the resident, I let him handle the scalpels, that's what happened. Or like, the patient was sick, so it's the patient's fault. That's why this complication happened. That's fine. I think that's okay to say. But as long as you leave here and you go like, oh my God, I really screwed that. I'm never going to let that happen again. As long as that process happens, I think we're good. But then, quality improvement, what's quality assurance? I think quality assurance is kind of an institutional responsibility that we have as a department. We have an obligation, ethical and otherwise, to provide a framework and an environment to ensure that quality improvement happens, and also to promote processes so that we can measure quality, we can set standards, and then we have an alert process that tells us when something is out of standard so that, again, we can course correct. And then underpinning all of this, underpinning it all of it, I think, is the fact that the patients and the trainees come first. There's no substitute for safe patient care. We all have an obligation to make sure that that happens. So how do we get here as a department? I think key to this process, it starts with transparency. It starts with a ability to reflect internally and a comfort to share what is happening to you, and then pass that information right on up the chain. You share what you learned so that all of us have insight into what you're discovering, and then that insight is shaped by discussions that we have in this forum. It doesn't have to be in this forum. It can be with a mentor, it can be with colleagues, peers, whatever. But there's discussion, and through this process, we get to where we want to go, which is the things improve. So does this matter to us? Yeah, I'd say it does. This is where we are, or were just a couple of years ago. I don't know. I look around the room here, and I don't think there's anybody left from 2003. But we were never in this. We were in a much different place, a little division. I think there were about 8 people in the division, and we lived in the Edwards building, which was pretty bad. But look at how far we've come in 20 years. This is, close to 2024. Had we never embraced change and made a decision to grow, we would never be where we are today. And we rank #1 in U.S. News and World Reports. We have a fantastic program that spans not only clinical care but basic science research. A massive department with international recognition now, and we get there because things change. You can go on to our quality improvement website, and you can see what is our position, our official position on quality. And this is a commitment that we make as a department to ensure that this is integral into our culture here. We expect departmental peer review. So when we all get together and we talk about cases perhaps that could have gone better, we embrace the measures and standards that the hospital is held to and is accountable to, and employ those in our practices here. We really look at opportunities to get to division and departmental level specific improvement projects and safety issues, and we're going to talk a little bit about that. And of course, we also get together and engage with our residents and fellows and pass on what we've learned. This is integral to our culture here. This is, I think, who we are and what we stand for. And as we welcome individuals into or under the Stanford umbrella, we're going to ask that people embrace our values, share our values, and also essentially integrate into the culture that we've established here. And just a few more speechy type things to say. This is, again, if you want to go onto our website, we have one that talks a little bit about quality improvement and some of the things that go on here. And then I think, up on the left there, you can read it yourself. These again are the things I think that we value here in our department in terms of quality improvement. Quality improvement used to be done very differently in 2003. We had a little paper sheet. I hope I didn't put somebody else. Oh, no, I didn't. Okay. But this is a tricky. We used to have a little paper sheet, and a patient died. Let me just fill that on a piece of paper. And then, somebody would be tagged. Who's got QA this week? Davros is going to do that. All right, so you're on call. It was the person on call would run QA. We would sit down in a room, and everybody would turn in their piece of paper, and whoever was doing QA would say, okay, let's talk about this case. And then that was it. And then the paper, it just went kind of into the circular file. It actually didn't go into the circular file. It went into a file thing that nobody ever went back and looked at. So there really wasn't very much. There wasn't really a coordinated effort to really dig into this, to mine this, to track this. We didn't have a database regarding, how many tonsil bleeds are occurring here. I don't know. We get them every once in a while. And it's rarely, if ever, and it's still the case, that anything in our department ever goes to the Surgical Care Review Committee. Most of you probably don't even know what that is, because you've never heard from them, and you don't do like committee stuff, or you haven't been roped into doing committee stuff. But in any event, we'll talk a little bit about that. But there was very little that went anywhere. We did very little with it. Now in 2024, we're a little bit more sophisticated. There's data that we can access that can tell us a little bit about our patient. In this case, it's pretty easy to understand what is our surgical volume, roughly what are the self-reported complications per month, what our case mix index is, et cetera. So it's gotten a little bit more sophisticated, and we've grown out our concept of quality organization in this service line. So now it looks a little like that. Instead of a bunch of people staring at a piece of paper in a little room and then throwing it away after it, this is actually what quality looks like from my perspective. We have the different divisions that report out their complications through our Smartsheet system. This feeds into a number of other data sets that flow into our department: static quality, Qualtrics, surgery, CRC, PARS, and BIOS. It feeds into us here. We analyze that. We take some of those cases to the M&M conference that we have. On the far side of the slide is our partnership with SHC, who sets certain standards. We'll talk a little bit about that. And that's called the operational plan. It comes out every year. SHC and the School of Medicine say, we want to see mortality for the hospital go down to this. We want to see readmissions reduced to that. We want to see well-being up to this. And once that's decided, they share that with us as in the service line, as with all service lines. And we can take those goals and bring them back into our department and figure out how are we going to partner with the hospital to make this happen. And we do that primarily through what we call the Quality Council and the ICDP, the Improvement Capability Development Program. All of this kind of turns and feeds what we do here as a department. And then the data and how it performed feeds on up to not only to our service line VPs on the School of Medicine, but also at large to the medical staff and the medical executive committee who's responsible for credentialing all of this. So it's quite, I think, more robust than where we were 20 years ago. I wanted to talk and point out this slide here because I think it's important. Our Improvement Capability Development Program is essentially an opportunity for us to really fund and drive quality improvement for our people, and also to integrate and team up with the hospital in terms of their goals. Now, the hospital and the School of Medicine invest 10% of our RVUs this year, 10% of our RVUs that is going to come back to us if we participate successfully in this program. And you probably hear me talk about this from time to time, and I ask people, who wants to go to CELT? Who wants to go to Wright? Everybody, what is CELT? What is Wright? But these are programs that help train and teach our faculty on the process of quality improvement. So as leaders, they can come back into their own shops, their own divisions, and actually affect quality improvement in a meaningful way. I just wanted to show a few slides about how we try to tie what SHC would like us to do with what we can do in our service line. So, for example, last year SHC planned for about a margin of about $323 million. How are we going to get there? Well, one way that we as a service line can do that is by increasing surgical volume, increasing throughput through outpatient visits, and also decreasing direct costs. So these are ways that we partner with SHC to try to get this. How about patient experience? We want to get a top box score somewhere around 84.3%. So we have access to data that lets us know how we are performing and how we can track that. Fortunately, we tend to shatter the records that SHC puts in front of us because we are a really good service line. Looking at quality safety, as I said before, dropping mortality is a high priority here for Stanford, as well as reducing harm from certain events to patients. And then this is in this program here, money is set aside to invite faculty and clinical instructors to go through these programs, CELT and Wright, which teach you about how to take on a quality improvement project and do it. And we joined, or ICDP for us started in 2017, and we've had 14 CELT or Wright graduates already come through the program. I think it's just been a really solid effort on everybody's part to try to embrace this. And if you look at the number of projects, the quality improvement projects that have come through this program since 2018, we've done 38 projects, which is a massive amount of quality improvement work, especially when you compare the size of our service line to some of the other larger service lines around the hospital. We really crush it. And I think when we go to these meetings, and Tina can probably attest, otolaryngology really stands out as the jewel in the crown of the surgical specialties because of how much work we do. And then if you look at how many publications that have been put out, I think this is just a very, very low ball number. But I've counted 27 from our faculty and trainees, again, since 2018. And then if you look at national or international presentations, 9 at least related to quality improvement. So you'd be surprised at actually how much great work is being done by this department kind of in this realm. And then when we talk about, how do we know what kinds of things need to be improved? What feeds this? Well, we get ideas because of our participation in ICDP. We get ideas from the Quality Council. The Quality Council is made up of representatives from the inpatient side, the clinic side, the program director, clinic chiefs, nursing leadership, and our quality consultants, so that we can tie and bind all the aspects of this process together: inpatient, outpatient, interventional platform, Redwood City here, try to tie it all together through the Quality Council, and certain key ideas or sticking points that people notice come through there. I would say the most important thing that happens, though, is what we discuss here in QA/QI. That's where we learn about most of our opportunities. And of course, this also affords an opportunity for the residents to execute their QA project. I wanted to just remind people about some of the important work that the residents have led here, as we've talked about over the years. A couple of years ago, we talked about a patient that died on the inpatient service during a routine trach change. Probably a lot of you, I think, were here and will remember this. We took that kind of a very emotional event and turned it into an opportunity. We looked at what happened and said, you know what, we really don't want this to happen again. How can we make this better? And this was a resident-led program to come up with the bedside tracheotomy exchange protocol. A lot of work. It was excellent. That came out of QA. We've had issues come up, as I think you know, where the residents are asked to see consults in the hospital and they don't have access to supplies and equipment, and so it gets taken from the clinic. And the clinic manager's like, we're out of supplies. The residents are taking them. The equipment's gone. What are we going to do? This type of an issue where you say, well, heck, we're asking the residents to see all these consults, but we're not giving them the gear to do it. Here's another project that kind of came out of an examination of a sticking point, the organization and the supplies now that are available on each one, so that if you need Maricel, it's on a cart there that you can take. Hopefully it's on a cart you can take. Is it on a cart? Yeah. All right, we're all set. Now
one thing that I'll highlight at this point, we now have a microscope as well in the operating room. That took a lot of negotiation back and forth, but everybody's welcome to use it. Dr. Chan and Feingersh can tell you details of where to find it, but we need to use it. Otherwise, we won't be able to purchase any other equipment for emergency room, because we really made a big deal that we need it. So do use it.
Operating microscope or a
operating microscope, yeah, to remove
that's great.
wax, foreign bodies,
In the operating room?
atraumatically in emergency room.
Emergency room, awesome. That's
So
good.
that's a new thing.
That's great.
Yes.
Got a lot of wax everywhere.
Good.
Yeah.
One of the more impactful things that I've seen the residents do is take on a project to decrease pressure injury ulcers from tracheotomy tubes. This was a huge deal for the hospital, because, as we're going to talk about in a minute, pressure injuries, these ulcers from the trach tubes, have to be reported to the California Department of Public Health. And they also account for some of the data that feeds our national standings, the Vizient, and that feeds other things like our standing and U.S. News and World Report. So very, very important. And this was put together in concert with the nurses and the residents to come up with a protocol to reduce this. And you can see what our rate was, and it just fell. It just fell to zero. And this won the Resident Quality Improvement Award for 2021 for the great work done. And when we discuss some of these issues with the SHC leadership, they're absolutely floored at what is actually going on here. And again, this comes from examining the reality ahead of us, which is that there's opportunities all around us to improve the care that we give. I want to throw another thing out here that you probably may recall, but again, we had a death on service. This was a young man who came out to our service and had a massive pulmonary embolism within hours of arriving on our floor. And the event was exceptionally traumatic to the residents that had to take care of this very nice man. And from that event came an opportunity to develop what is called the consult bundle, which is a smart phrase that residents can put into their notes when they're rounding on inpatients, that talks a little bit about what are our recommendations for VTE prophylaxis. Antibiotics, can they be on a diet? And then what's the inpatient follow-up? A great opportunity to close loops in communication with our colleagues on the inpatient side so that these issues didn't fall through the cracks. What had happened was our team was consistently recommending DVT prophylaxis for this man who was obviously at a very, very high risk. But for some reason, the main service elected not to do that, thinking that this patient was going to have surgery at any time. And they didn't realize really that the patient was a non-surgical candidate. So no DVT prophylaxis was ever used. So anyway, out of adversity came a fantastic idea. A few other things just to kind of explain and point out the depth and breadth of the work that actually comes out of here when we get all together. So again, quite a long time ago, 14 years ago, we had a run of esophageal perforations that were happening here. It was our practice a long time ago to routinely do rigid esophagoscopy on all patients that were coming in for definitive treatment of head and neck cancer, looking for an unknown primary. Why did we do that? Because that's how we were doing things in like 1984 or 1994. So we noticed that a number of individuals were having esophageal perforations and they never had any esophageal pathology. So why were we still doing this? Gabe Sau wrote this up and presented this at the Academy. We were up here one day, I remember distinctly, one of our illustrious graduates talking about an oral commissure burn in a tonsillectomy pediatric patient, and how excruciatingly difficult it was to go out and have a conversation with the family that this beautiful little child who had come in for a routine outpatient surgery now had a very deep and disfiguring burn over the commissure of their mouth, which was going to mark them for the rest of their lives. And really digging down here, we realized that we were using mouth retractors that weren't insulated and bipolar forceps that weren't insulated. And the question was, how in the heck are we even doing this? And from that event came an opportunity to re-examine what was in our equipment and get rid of this. And I don't think we've had an oral commissure burn in probably 14 years or so. So sitting here and talking about these issues and facing these what can be a difficult event from adversity comes opportunity. So we've talked a little bit about that, and I think you're getting a sense of why I'm putting out a pitch here for us to be here and talk about these things and get it out in the open. But people probably, I think, have some kind of perception that Big Brother is watching us and is aware of everything we do. Don't you think so, Mohammed? You think that, don't you?
Yeah.
I know we talk about this.
All the time.
That's why he's watching me, and they'll just tell me when something's going wrong. Well, you'd think that, but it's really not what happens. We have a lot of mechanisms in place to try to track quality, and I just kind of listed them all here. There's tons of databases that track kind of what we're doing, from the SAFE system. So if something happens, you can file a SAFE report if you think something unsafe happened here, to some of the things that I work on the Committee for Professionalism, patient complaints and colleague complaints. We get some feedback from our patients through the LTR scores, but probably the most important thing that we do here is the self-reporting of complications, because it's really, we have the insight into actually what's truly happening that probably really meaningfully matters. Despite all of these layers and all of these people in committees, they don't have a good sense of what's going on. They don't have the insight into our service line like we do. So I think self-reporting is actually very key. So to that end, we had a discussion about a month or two ago, a little bit about QA when we broke out here. We talked about barriers to reporting our complications, and one of them was it was hard to access the reporting system. So I want to thank Olya, who really has been working with me on this to make this a more 21st century thing. This is a scan code, and I'm going to go ahead and send this on out to everybody. If you have a complication and you have an iPhone, you can scan this and just submit the data right there in real time. We're going to post these up in the resident room as well. So if you need to access our smart sheet, you can do so in an easy way. This is what the smart sheet looks like. It's not the paper record that we had 20 years ago. You just log in, and it's going to capture some things here. more importantly, the MRN, and information about, excuse me, what was the complication, and that's it, and just send it on in. When we compile all of these types of events, this is kind of what we can get. We can get a sense of the volume that's happening here, which is very helpful for us to kind of track. And you can see how things change month by month, year over year. There's been kind of a slow, gradual deterioration in self-reporting, despite what we thought was making it easier for people. Now, as of this year, one of the things that we're working on is to make the data that we gather more clinically meaningful at the division level. So we are creating division level reports. So now we can track events that happen in every different division, and then have an insight year over year how this changes. So, for example, this was what was recorded in fiscal year 21 to 22 in terms of our total volume of complications. This is where we are in fiscal year 22-23. So year over year, we can track changes. And then I don't have this prepared and ready to go yet, but we will be having division level reports that can go to the division chief and also be accessed by a division chief so that they can look and say, what's actually being recorded in the division, what is actually going on, so that we also have visibility over that. I'll make a statement. Yeah.
So I think comprehensive is missing from that list.
Comprehensive is that adult otolaryngology. I got to change the name. Yeah. Now, when we get together here and we talk about issues, really, hopefully I'm trying to convey to you that the goal here is to generate a discussion where we can actually affect true change. It's meant to be educational, and it might surprise you, but this is not peer review. What we're doing here is not peer review. Peer review, by definition, means a gathering of peers that evaluate a level of quality and then make a decision about whether the bar of the standard of care was met or not. That's not actually taking place here. So nothing happens when we talk among themselves. Quan's not going to get in trouble. I'm not going to get in trouble. Nobody's getting in trouble. It's just a discussion, okay? And we're really looking for it to be as frank and open as we can so that it can be as meaningful as possible, and most importantly, identify these actionable trends, create a data mine for scholarship, and then also to kind of encourage this culture of professional responsibility and ownership. This was my patient. This happened to my patient under my watch. I want to explain to you what happened, get your insight. Maybe we can figure out how to never have it happen again. We talk a little bit about, or I think there's some concern about how the cases get selected for QA here. They're based on educational merit. That's really it. The more educational merit that they have, the more likely they are to pop up. Some months I get no submissions at all, or maybe one submission. And so, well, maybe that one submission will get tagged. I don't think there's much value in talking maybe about a post-tonsillectomy hemorrhage when there maybe wasn't anything to learn from it. But there may be value in looking at rates in aggregate and say, maybe we're missing something here. Maybe we should be looking at a trend that a single case can't tell us. But we also, in this session, look at referrals from other departments. Other departments may have a concern about the care we provided to one of their patients. We get referrals from risk management. So basically the office that defends us from malpractice litigation will send us cases and say, yeah, we have this question here. We want to know if what happened fell below the standard of care. What do you think? I wanted to talk a little bit about never events because this comes up as well. If those occur to us, we review them. Referrals from other committees in the hospital, and then we tend to review deaths. The death review is not, again, we want to track these things because death in our service line, death in a practice like ours is so rare and so unusual that when something like that happens that it's attributable to our service line, it really radically skews our metrics. Now, we're not talking about you consulted on a trach for somebody that was dying on a ventilator to ease their passing. No, that's not what we mean. We routinely capture those things. I don't really care if we capture that as much, but does end up getting discovered. So, never events are things that are quote unquote never supposed to happen. And they're of such magnitude that the CDPH, California Department of Public Health, wants to know about it, and the hospital is required to file on it. not later than 5 days after the event, and in some cases, within 24 hours of the event happening. Can anybody here think of an adverse event like this that we would have to inform the state about?
Wrong
Tree.
site surgery.
Pressure sores, right?
Pressure sores, yes. Pressure-related injuries that are of a certain depth. That's exactly right.
Wrong site surgery.
Wrong site surgery. You got it.
Retained objects?
Retained foreign body. Exactly. Anybody else? I know you. Where's Belsky? Belsky, give me one. You know. An exploding piece of equipment.
Was I supposed to report that?
You were. But it might surprise you, and it surprised me, that I was looking through kind of this list, and I realized that I think I've seen in every single example of one of these complications here at SHC, wrong body part. Do you know we have a work group going right now trying to solve that, because we have had so many of these events here in the last year. Can you believe that? I mean, come on. Wrong patient, wrong surgical procedure, retained foreign body, we get a lot of those, lots of them. Intraoperative or a death in a class 1 patient. So somebody that came in for an elective case that was healthy and died, they want to know about it. Not a lot of the folks like that we take care of that they're really sick. How about this related to product or devices, right? We were talking about a device the other day.
For
Yeah.
the previous one, if we have so many of them across the enterprise, are people not doing timeouts at the beginning and at the end?
So what it's interesting when you look at this about how is it that actually happened. It's interesting. You see at first in the preoperative H&P that the attending says, I'm operating on the left arm. And then you see something like the consent gets written as right arm, or the consent says right arm, and then the left arm gets marked. And there's supposed to be, I know it's crazy, there's supposed to be these processes that capture this. The nurse is supposed to mark off and say, did the consent and the H&P agree with the marking on the body? And sometimes it just slips through, even when we do a timeout. That's where it's getting caught, is at that point. Yes, Sam?
Just on that point, I think that, I remember when we instituted timeouts, and we've been doing them in Washington for years, and they hadn't been doing them here, that we were much stricter about it. It's supposed to be done after prep and drape. And I've noticed many times nurses now pull out the consent and start doing it while I'm injecting or something before the prep and drape.
Yeah.
That's one of the things that leads to wrong side surgery or what have you.
Mm-hmm.
So I think that just generally around, also marking is sort of fallen by the wayside in the pre-op area. They used to make me mark the nose all the time, even though it's like midline. I don't expect them to start that again, but I think that some of the teaching around the strictness of the protocol has fallen by the wayside.
Yeah. I actually learned something new the other day. I didn't realize that proper marking now is the initials of a senior member of the operating team have to go on the patient at the site of the marking. I just thought it was make a mark with a blue thing. No, it's actually our policy is the initials. Zara knows that. Zara's nodding here. She knew that. Why didn't you tell me, Zara? Why does we have to wait for this form? Don't embarrass me anymore. Yes. Go ahead.
In your investigation on wrong site,
Yeah.
are you looking at radiology mislabeling?
Sure are.
Yeah.
Absolutely.
I've had several cases where it's clearly a lesion on one side
Yeah.
and it's listed as the other.
Yeah.
I know, like on our ultrasound equipment here, they have, this touch screen where you can toggle between left and right just by touching the same button over and over again. It switches back and forth, and it's so easy to have it go to the opposite side of what you intend. So I don't know, I think that's bad thought for design, but
Absolutely. So like this kind of stuff, like if this happens to you, share it, let us know. Because I think like I didn't know that. Like I heard the other day, I remember we were talking about that tonsil thing and like the way the foot pedal is designed, and it's like you can't see where you're stepping, right? That's an issue. I'm sorry, Uche, what were you?
Yeah, I was just gonna address what Sam said, because I was in that QuipSec meeting where we talked about the
Yeah.
wrong side surgery.
You saw that.
And I think one of the issues actually is not the timeout, because when we do timeout, it's based on what's in the consent, on what's marked on the patient. And I think a lot of the issues have been that what's in the consent doesn't actually match reality. And there's discrepancies between what's documented in the chart from previous clinic visits to what actually ends up on the consent. So I mean, the real solution would be to sort of like make sure that everything lines up, right? You know, documentation in the chart, imaging, whatever tests, and the consent.
Actually,
Before
to your-
timeout.
To your point, one thing that also has fallen by the wayside from our side as physicians is that we don't often put the laterality of the graft or whatever we're harvesting on there. And I keep correcting residents on it because it used to be there's when they go to the operating room and it didn't have that on it, but now it'll say like your cartilage graft or something instead of right or left rib graft or whatever. So I think that on all sides, we've kind of become a little bit lax.
Yeah.
All these things line up.
Absolutely, yeah.
Mentioning imaging, I think we've definitely become lax about putting imaging up at the beginning of the surgeries. And, you know, we have the ability to put up the radiology imaging or our laryngoscopy imaging before the surgery and have it up during the timeout and confirm. I think that's actually like another line of defense for this, because imaging reviewed is actually one of the lines of timeout, and routinely just say, oh yeah, imaging was reviewed, but we don't have it up.
Absolutely, absolutely. Yes, Mohammed.
Yeah, I was gonna say another thing that we can consider. I'm not saying the residents should have like portable ultrasounds to use, but I think if we like, if you ultrasound like before the surgery, that's also another way to really confirm which side you're doing for a lot of like soft tissue cases. So
Yeah. Yeah, good thought. But it's amazing that to this day and age, all the effort still goes on. I'm gonna run through this real quick, but it might, probably doesn't surprise you if there's a contaminated drug. I remember one time we had a surgeon here who demanded to use a drug on a patient even though it was contaminated and expired, and he tried to bully the pharmacist into giving it to him and using it on a patient in the OR. And it's like this, these things come up, and it's like you can't use an expired drug on somebody. We've got to have some safety barriers here. If a device fails, air embolism. That was something when was the last time we saw an air embolism?
That, if you could go back, that segment seems a little bit rigid, use of a device in which the device is used for functions other than as intended. I mean, we often adapt.
That's not what that means. It's not what you're thinking, like using an ultrasound to look at the thyroid, do a FNA versus put an IV line in. No, it's more like, I don't really know what all of that means. That's not what that means.
There's
It's
also
like,
patient death and serious injury associated.
Okay.
yeah, and it's a serious, yeah.
Okay,
So,
okay.
and then this happens too. We just had a guy go up onto a floor in the middle of at 3 o'clock in the morning, take a patient, put him into a wheelchair, wheel him out the front door, and drop him off at a Verbo. And like, what are you doing? So I mean, like this stuff kind of does really happen. Patient elopement, especially if something bad happens to them. I remember when I first came on staff here, one of my patients eloped out of C2. He went up El Camino to go to Burger King. He found him walking on the road here with his shake, and then brought him back here. And I had put a trach in the guy for that. So, suicide. You remember the gentleman who threw himself over the rails in the atrium? That wasn't too long ago. We talked about this, medication errors, as you can imagine. But again, harm or death, patient fall, decubitus ulcers. This might surprise people, failure to follow up or communicate laboratory or path test results. Yeah, patient suicide. What's very instructive? You all get the California Medical Board newsletter. You probably don't, because it probably goes to your junk file. I would highly recommend, if you don't, read the actions that the medical board takes on people. It is sobering. They are very, very busy. And you'd be surprised at what doctors are getting their licenses yanked for. This is one of them. So, it's very interesting out there. Maternal issues, I think, as we talked about. These are some things that you can imagine. Patient's death or serious injury. We had a patient got lit on fire here about 2 years ago at the bedside during a procedure. Did you hear about that? Yeah, it really happened here. Yeah, they were using chlorhexidine, and it didn't dry, and we're doing a bedside debridement, lit up the little portable bovie, and then boom, patient had 3rd-degree burns. So it was interesting. Patient deaths from restraints. I don't really mean to say this because it's titillating, but what I'm here to tell you is that it seems nuts. How can that happen? How can that happen in a place like this? It does happen in a place like this, and we're really great. Do you remember this, last year, the MRI, the bed that got sucked into the MRI machine at Kaiser and it crushed the nurse? She's alive, I'm not happy. But she got injured and stuff. So, wow, how does that happen in 2023, 2024? Criminal events, people coming in here and impersonating people, abducting patients, as you can imagine, sexual abuse, assault. We get a lot of complaints like this, lots of complaints. I went into the ER, doctor assaulted me. It's more than what you think, but a lot of people they may be kind of psychotic and they think that this happened. We get a lot of complaints like that. I remember I was at UCLA as a resident and a guy came in who was impersonating a physician. The LA Times called me up about a year and a half ago asking me if I had any follow-up on this. And the guy ended up impersonating one of our urologists walking around, going into the OR, et cetera. It actually happens. It happened here not too long ago. Somebody was tracking some of the plastic surgery people. They found themselves a white coat and was coming through the doors of ASC. When the door would open up and people were coming to work, and they were going into people's OR and just kind of showing up and like, oh yeah, I'm visiting doc and watching what was going on.
I'm with Dr. Wong.
What's that?
I'm with Dr. Wong.
Yeah, no, Dr. Wong invited me here. But again, these things happen and they're happening here, so it's important. I think there's a perception that probably what happens here, like, stays here, like people won't know about what's going on, and that is so far from the truth. I was looking at news reports last night about bad stuff happening to hospitals and doctors, and it is so easy to find this stuff all over the internet. And this is incredible. And some of these stories are kind of dated, like 2008, 2010. This one's from 2022. This one was just like an hour before I got onto the internet. The community, the people at large, I think, have less tolerance for this. They look at hospitals and they look at physicians as they're required to be at a higher standard. And when we fail, that is we are in people's targets. People are paying attention, and if you read some of the comments about some of these stories, people that read them, people are outraged that this might happen in the United States at hospitals like ours. Now you might go, well, yeah, Anaheim Regional Medical Center, that's got to be a dumpy place. Who cares about that, right? Well, why don't we talk about our peer institutions? What gets out there in the news? This is just a whistleblower story up at John Muir. We're affiliated with John Muir. Surgeon in Massachusetts General double booking controversy, reprimanded for substandard care, August of 2023. This gentleman is on our staff now. My alma mater, patient safety scores low. Who'd think that data would get out, into the news? Stanford Healthcare loses again in court, 468 Medicare billing fraud.
I'll say that rules about double booking are much more rigid in the Northeast, and even consent forms are. For example, consent forms in the Northeast have to list everyone who is participating in the case, the resident by name, the fellow by name, and the patient has to agree. Mm-hmm. And likewise, physician's presence in the operating room is being tracked. You basically have to swipe your ID as you are coming in and coming out. So it's actually documented whether you were there for most of the case, and in particular, whether you were there for critical parts of the procedure. So those changes may be coming our way.
Absolutely. The nurses are supposed to track us in Epic. I don't think they do it as robustly and as intensely as what you're talking about, Tina, but that's absolutely right. Yeah, absolutely.
Can you tell us more about the Stanford Medicare fraud that we were?
Yeah, this goes back to claims as far back as 2008 that with the institution of Epic and our electronic health record, that has allowed physicians to kind of, and it's true, I think, acknowledge things like, did you do a complete review of systems? Yes, and just click the button and there it is. I think it's easy to say, you did this great big body of work because people copy and paste notes forward, and that's a little bit about what the lawsuit is about. Yeah. I don't know all of the details, but I think there's probably something there. there's something there. One of our faculty came up to us to talk to me when I was still chief of staff about the moral trauma that some of the house staff were undergoing and some of the physicians were undergoing, having to basically click that button and say, if I just click the button, I get a level, I can bill for a level 4 instead of a level 3. And what should I do? I didn't do everything that was on here. It's a real thing. The moral and emotional burden people are carrying, I think, from the electronic health record, but that's what that's a little bit about. Yeah. There are personal failings, okay? I put this up here to talk a little bit about just some of the Stanford physicians who have come under scrutiny as of late. We also have an ear towards the professionalism of individuals. And are we getting any signs from people that there's something wrong, okay? We actually have really good sense. The residents and trainees, I should say, pick this up too. When somebody writes to me and says, I think that there's something wrong with somebody, my advice is that we listen to that very, very carefully, because none of this stuff that we see up here was occurring in a vacuum. There I think are often signs here, but you see how the media is so ready to just grab these horrible, lewd, stories, especially if it features in a prominent person like a Stanford physician or our president. These are just some more things, again, I track professionalism problems here in the hospital, and I'm worried about when people, for example, chronically abuse the staff. You're finding they're getting fed up with it. They're not going to come to work for us and come here and be abused in our center. And more importantly, they're not just going to leave, but they're going to shed light on it. And when that spotlight goes on, it's going to, it gets out there. Look at how demonstrative some of these headlines are. It's pretty bad. So it's really, the media takes notice. And when it all comes down to it, we can spend a long time trying to build up a first-class reputation, but one individual, one event we can lose it all if we're not careful. So I'm going to wind up now and leave some time to discuss. But again, based on some of the discussions that we've had, this is what I'm recommending and asking all of us to do as a department, okay? The question came up is what things should we be reported? And I think a simple way to look at this is that if there's something that happens that any reasonable person would consider to be a complication, okay, that should really be reported so that we have some oversight on that. If you would disclose that could happen to a person as part of the informed consent process, bleeding, infection, perforation, leak, et cetera, et cetera. If that happens, it should go into the database. Or if it's so rare, you didn't consult the patient. If it's so rare and it comes up, by all means report it, because this is again, how we learn and grow and where there are educational opportunities for us. So from my perspective, this is what I would say should be your threshold for reporting. As I said before, we're going to have division level reports, okay? That the division can take internally and act upon. Now my advice is that this is an opportunity to leverage it as you will. You can get out of the system whatever you put into it. If you want to track stitch abscesses because you think the hospital is buying a different type of stitch and you're seeing an uptick, we'll use the system and report that. And we'll take that data and go make an argument to go buy something else. If you're using Miracell and you've had a run of you're like, I packed that nose great. The Miracell, people are still bleeding. And you're like, what do you know? We've been using expired Miracell. That's why it's happening, right? If it might seem mundane or trite, like it doesn't have to be all deaths. It doesn't have to be all DVTs. It can be anything you want. Division chiefs, if you give people this data, they may be able to take it and analyze that and use that for something. When should I report? This question comes up all the time. There's different ways to report. When it occurred, or a lot of people, they go, I don't really want to say anything until I know how this comes out. I don't recommend that we delay. I really recommend that we report the day the event is recognized, because the problem is that people forget. You just forget, okay? It's not, you haven't done anything wrong. You've got 1 million people to see. That complication happens, it gets out of mind, and we're not tracking it when we lose track of it. So please do report it as soon after that it occurs that you can. The date and the event is recognized as my recommendation. We talk about who should report or who's responsible for reporting. I'm just gonna come out and just say, the faculty, we're responsible for reporting. The data reflects on our credentials, it reflects on our records. You can delegate whomever you want, okay, delegate, but follow up. Make sure that it gets in there. But the attendings should be ultimately responsible for this. So I'm gonna stop here now. We're almost done and open it up. But so as a group, this is my recommendation, my proposal, my ask to all of us is that we use that Smartsheet program and we start really reporting, okay? The reporting minimal threshold, we talked a little bit about that. If it's something you disclose normally, go ahead. Report it within 24 hours, delegate, but be careful, make sure you follow up. And again, we're not here to traumatize, emotionally scar anyone, okay? As a matter of fact, Jay Karnayak is now going to be helping select the cases. So you don't think I've got something out for all of you or something like that. So Jay Karnayak, he can select the cases. I don't care. I just want cases on. And then please, this came out from our discussions last time. Please be brief. When I have an admiral that I report to, and at the beginning of every presentation, she says, be brief and be gone. Please be brief. Don't do a literature review because we actually can use the time to maybe churn through other cases and stuff like that. So unless it's really relevant to the case at hand, it's like, oh my God, this is the first one ever reported in literature. We'll write a case report about it. But that's all you need to really say about it. And then again, it allows us more time for discussion. So please be brief. There's a template that's floating around out there. All you got to do is fill out the 5 or 6 slides, hit the line items, use the taxonomy. Let's all then talk about it. That's really what the value is of the meeting. So thanks for letting me talk the entire time. I really didn't want that to happen, but I wanted to kind of clear the air and level set a little bit here about what I think, how we should go forward. Anybody would like to make any comments or questions? I'm sure there's a lot to say about
What's
this.
the time frame for complications if surgery happened today, and is it a month out?
So that's a good question. I would say, like for the hospital, we would kind of look at 30 days, okay, 30 days. But we do know, I think that we're aware of things that might happen on the outpatient side. And again, I would look at it as what's valuable to all of us. Let's say Sam puts a facial, maybe Sam, you're using a new implant, right? And you're like, in 31 days, it looks fantastic, it's great. But then you notice 6 months later, the implant has now reabsorbed and gone or migrated. So like for Sam, for you, my recommendation would be report that. Because as a division chief, you're gonna get that back. And if other people in your division are noticing the same thing, we have a device failure problem. Or cochlear implantation, maybe there's a different brand or prophylaxis, antibiotic prophylaxis has changed and it's occurring beyond 30 days. I would say report that, but within 30 days is kind of how I think the hospital looks at it. A death within 30 days, generally thought to be related to the surgery, readmission, etc. Yeah.
There's been a observation that there's a very frequent incidence of corneal abrasion. The nurses in the PACU say at least once a week there's a patient in the PACU with a corneal abrasion. I don't know how do we go? I've tried to mention it to the residents, say, does somebody take this on as a QI project? But it's not really our responsibility or our role to prevent it. But is there some way we can get a collective effort to prevent those?
Yeah, so the first thing I would say is that write a safe, okay?
Mm-hmm.
If it's not written down anywhere, it didn't happen. We don't have proof, okay? So it's gotta be written down. We've gotta be able to track it. So enter it into the safe system. The second thing is I would say is that leverage your representatives in the service line to try to find out what powers that be own that. So I can tell you, for example, Sam Wall owns that, okay? Sam Wall oversees the interventional platform. Probably Sam knows that these corneal abrasions are happening, but they may not know the degree or the frequency. So if you've noticed something like that, my advice to you is that tell me, say, Ed, these are 5 people in the last 5 weeks, all of them with corneal abrasion. I'm gonna, I don't know if I can fix it, but I can certainly spread the word and send that on up to Sam Wall and say, Sam, this is a problem that we're having on our service line. He says, you know what, Ed? That we're seeing that on plastics and urology and here and there. We have a problem. Let's get an ad hoc committee together to fix this. The worst thing you could ever hear is let's get an ad hoc committee together. Because that means the problem's not fixed. But you can share it and report it. And like, if you don't know, I will try to find the process owner for that.
Sounds
Yeah.
good, yeah, thanks.
Yeah. Yeah.
What about near misses? I've had a couple of times where we caught something before it happened.
Yeah.
And in some instances, you can say, oh, it's because it wasn't documented, and that would be the error. But some instances, it sort of just comes up and then you catch it and then nothing happens, but it would be worth sharing so that doesn't happen again.
Absolutely. Near misses are God's gift to us. God says, I like you. You're gonna learn from this. So that's a golden opportunity. So those are things that ought to be shouted to the rooftop. Report it, share it, put it in the safe system. You're right. Now, I will just tell you here that like, I don't think anybody's ever gonna accuse the Stanford bureaucracy of being too efficient, too effective. Okay, maybe it's a little bit overburdened with middle management, and maybe that clogs the wheels a little bit. But, and so, yeah, I mean, I can understand a near miss might happen and then we don't learn from it like we should learn from it, but report that because that's a golden opportunity. Yeah. Yeah.
Do you want us to report like more, I guess, routine complications like post-tonsil bleeds when they come on?
Yeah.
When we're on call? Like,
Yeah.
Cause I feel like it happens all the time, but we don't necessarily, submit.
You think that we as a department get about 2 tonsil bleeds a year? If you actually looked at our metrics, but we don't have a problem, we only get 2 a year, how can, what are you talking about?
What if it's an outside?
So, I didn't mean to, oh, please, yes. Maybe people are giving too much, Lovenox pre-op, maybe they're getting too much heparin, maybe they're getting Lovenox and clopidogrel for all we know, and that's what's happening, right? So, yeah, so please do report it, yeah, yes, I'm sorry.
If we're taking care of an outside tonsil bleed or outside, whatever it is,
Yeah.
is that also
Yeah.
reported?
Good, yes, I would say, because we are growing as a network. And that outside tonsil bleed, it actually might be related to somebody within our network. So yeah, please do let us know, okay? Even, that's probably, sometimes it might not be, something happened at another hospital, but we don't lose any ground by actually, by looking at things like that, yeah. Yeah, cool, yeah.
And just clear the air for the M&M presentations, because it's something that someone sent me was like do a lit review and do all this, and so spending all this time. Can we just kind of clarify what do you mean by be brief? Like is it how many minutes should we aim for?
5 minutes.
5 minutes?
Yeah, real fast. The real value in meat comes from, let's discuss, really, go ahead.
I understand we're supposed to be doing debriefs now as part of our surgical, OR. So, I mean, I think that could be an opportunity because I think sometimes it's difficult to differentiate, between an expected, situation that happens in the OR versus an actual complication, and then that might be a time to, clarify what, needs to be reported.
That's very true, because sometimes there's a misunderstanding. You find something and you have to change direction, or the tumor was wrapped around the internal jugular vein. I now need, we got into the internal jugular vein, we're gonna take it. Somebody might look at that and go, oh, well, Dr. Bakey, that's an accidental puncture and laceration. Yeah, no, it really isn't. This is a modified radical neck. I took the IJ. You're right, that it's an opportunity to kind of clarify with the staff. The other thing that is happening is we're seeing quite an uptick in missing specimens that never make it to pathology. They've chronically been mislabeled, okay? I don't know what your thyroid is like. I don't know if that gets mislabeled as, I don't know, there's something else all the time. But they go missing, and this is a real problem. Fred's right, there's now a debrief. When we're done with the case, the nurses will say, hey, doctor, I want to talk to you. Did you do this? What was the thing? And this is an opportunity to say, I gave you, there should be 5 specimens labeled X, Y, Z, A, and B. That's what's going to pathology, right? Right. There's a great opportunity there to help kind of fix some of these other problems as well. But you're right, Fred. You can clarify that. Like, oh, hey, when I got into the IJ, I meant to do that.
Thanks.
Great. I think we're at time. Thanks, everyone. Have a nice day.